Hi, everybody who's here so far. Are you ready? Kind of, sort of, maybe, maybe not. I'll wait for everyone to gather, but I just want to do a little review. If you feel like you'd like to, if there are any spots that are a little ambiguous for anybody. And I also just want to kind of align your thinking and attention in the right way so that there's minimal stress taking this exam. It's going to be fine. So I don't know if everyone's going to join the little review sesh, but I'll leave it up to you all. We can chat for up to an hour if you want. It's up to you. And as people are gathering, I'll just wait. I don't want to say anything important. Hi, everyone.
Hello.
Okay,
Hi.
so there are only about 50 questions on the test, maybe just shy of that. And I give you a couple bonus questions too. So it's not going to take the entire class time. So, in my mind, I kind of roughly planned maybe we do about an hour of review and then you can take a break. And then, at the pace of Hi, Amy. So at the pace of what is, considered reasonable for your board exams, it's about a minute and a half per question. So try to finish within 75 minutes. But if you need a little extra time, that's okay. And I'll repeat because I know people are still gathering. We won't start the test just yet. If you have questions, don't be afraid to ask. I want everyone to feel good going into this. So let's see. I know there are a couple people who probably won't be joining us, but so let me just start. Hello, Carrie. I'm just keeping an eye on everyone joining. Okay, it's just after 1:30. All right, so I know that test taking can be stressful in general. So, this is a tricky forum in some ways. I think maybe this will be a tad less pressure for you all remotely. When I was in trauma and ortho, there was a practical part of the exam. So we had the written part, and then we had to line up, and we were given a random ortho test that we would have to perform on our teacher. So that was very stressful, I remember. So we won't have any of that. It's all descriptive, right? So you can take a deep breath there. And just, this test, maybe when I teach review and assessment, sometimes I recommend, and this doesn't always work, but sometimes it's nice to, especially if it's a case study, right? So if you come up on a question and you see, and this is not just for my test, but this is just test in general. If you're going to run into questions where you see a lot of words and it's like especially with case studies. So in that case, if it's kind of overwhelming and you just see this loaded question before you even read it, sometimes it's nice to just scan the answers first. So before you read the question, take a peek at the answers, and then your attention is already kind of tuned before you read the question to kind of know what you're looking for. So that could be super helpful in this test in a handful of cases. So I give you that advice. I promise I'm not trying to trick anybody. So it's pretty straightforward. And like on any test you take, whether it's in this class, another class, or on your board exams, sometimes it may seem like there might be more than one right answer. And there sometimes can seem like there's more than one wrong answer. That's usually the case. Again, I'm not trying to trick anybody, but if you see anything like that, know that a common theme for the testing in our, especially in our board exams, is to pick the best answer, even if there are a couple of them that might be, possible. Do not even think about airing any grievances if there's something you studied that does not show up on the test. Again, I would way rather have you feel over-prepared for the test, but solid in your understanding of the information when you're out there in the clinic. So that's a good thing. So if you take the test and you breeze through it and you're like, well, that was easy, I studied a lot, do not complain. I do not want to hear about it. You're welcome. Just yeah. Well, hey, it happens. It seems like everyone's here. That's going to be. So again, for those of you who missed it at the beginning, it's just shy of 50 questions. So I'm going to give you about 75 minutes. It should be plenty of time. That's about 1.5 minutes per question, and that's how long your boards give you. But this isn't review and assessment. So if you do need a little more time, it's totally fine. And once we decide that everyone's ready, we'll just start, and you'll probably be able to leave early today because I don't think it will take the entire time. And again, now that everyone's here, I'm so sorry for the little typos. Last Friday, if you remember, it was a crazy, weird day. Lots of distractions here. So I was a little frazzled, and I apologize for that. But I didn't realize that the corrections didn't save, and I had a feeling I missed one, and I did, and it was brought to my attention. But again, most of the little errors on the PowerPoint from last week are of no consequence to the test. But again, thank you for those of you who discovered that. One of them that actually didn't make it on the corrections that I just want to bring to your attention is, so for a scaphoid fracture, we were talking about that in the context of the wrist. I'm going to pull up this slide. So it's this one here. I'm assuming you can see it. So falling on an outstretched hand, as you remember, can be problematic for a scaphoid fracture, and those are tricky because they're kind of difficult to pick up on an X-ray. Not always, but it can be missed, and that can lead to some red flags. So the error on this slide is in the second bullet point here. So moderate to severe pain upon palpation of the scaphoid region near LI5, not lung 5, and lung 9, right? So in the anatomical snuff box at the base of the thumb and right around the corner, just below the palmar surface of the thumb, that's where you're going to feel tenderness. So that's not going to be of huge consequence on the test. That, you know, I think I had lung 5 instead of LI5. You'll be fine. But I want to point that out, and I'm again, I apologize for the wrong PowerPoint going out. So did everyone get the corrected slide on the ulnar, the Tunnell's test for ulnar, distal ulnar neuritis?
Yes.
Okay, good. I'm not going to ask you a question on that. That's not or on that slide necessarily in the context of the error, because that's not fair. But I just want to make sure you guys all have that straight. The Guyan canal is just ulnar to the carpal tunnel space, right? So the median nerve is right here. This is where you would tap at the base of the palm. And then if you shimmy on over to the pinky side, right here is where you would tap for the Guyan canal. So don't stress about that. But again, I just want you to, I don't want you to have incorrect info. What else did I want to say? I think that was it for, like, you know, test prep, but I'll kind of take a peek at the study guide, and I'll run through just some quick review, unless anybody wants to start with questions about a particular area. Is there somewhere that feels just a little bit cloudy for anybody out there? And don't be afraid, you know, I mean, most of the time, someone who's courageous enough to ask a question, most people have it too. So, does anyone want to throw something out there?
I have something.
Okay.
It's not specific question. It's just a couple areas that I would love for you to just press again to, you know, kind of focus on.
Yeah.
Let me find it here. Here it is. Okay. So 2 of the areas of differential diagnosis that I would love to just, like, you know, discuss a little bit more during this review are in the differential diagnosis between supraspinatus tendonitis versus impingement versus a tear. I mean, I see the 3 different tests for that, but I wasn't sure if there was anything else you wanted to say about that, and bicipital tendonitis and what distinguishes that from a possible tear.
Yeah.
So those, basically the differential diagnosis on the shoulder, and then also on the elbow.
Okay.
So especially between ulnar neuritis, thoracic outlet syndrome, and C8 cervical.
Gotcha. Good questions. Okay.
Thanks.
Yeah. Does anyone else have anything to add to our list to review? And we'll just kind of take it down the line. All right. I'm going to pull up a couple things. I also want to just make sure, is everyone clear on the planes of motion for movement? Because again, this isn't a review and assessment class where I'm trying to sneak in as many multi-level questions as possible, but that tends to be in trauma and ortho, and until you really understand, like, what shoulder abduction versus flexion is, sometimes just the language could be a sticky spot. So I just want to make sure you're all comfortable with those directional planes of movement. Okay. And if not, feel free to shout it out. So that's a really good question that you brought up, Suzanne, about tendonitis versus a tear, right? We don't always know for sure, right? Especially because a tear can have multiple grades, right? So a full thickness tear, the punchline, and this is very clinical. If something's actually completely torn, one, depending on what it is, that might be very visibly obvious, especially if it's in the bicep, because the bicep, it's usually the long head. But either way, whether it's the short head or the long head, it's going to retreat up the arm, and you're just going to see this little tiny hunk of muscle right here. So it's no longer going to be tethered to two ends of a long bone or a longer bone. It's just one of the sides is going to snap. It's usually the distal, and it's just going to it's going to fold right up. And I've seen that several times in different places, whether it be in the thigh or the arm. And in that case, if you really do see like a significant collection of muscle tissue that should otherwise follow a longer trajectory, and if it's in an acute stage, there might be a lot of bruising as well around that. That's when we suspect a tear upon observation. So that, you might refer to the patient's primary care to get some imaging to confirm, but sometimes it's pretty obvious. Other times not, because as we've discussed, tears can be just very partial, right? So if we just shred just a few fibers of the tendon, it can be still hanging on and still anchored, but by, a thread, right? Or more. Those can heal, but they take time. And if it's severe and maybe not fully torn, but partially torn, another thing you would expect to see is significant weakness. So the Codman arm drop, especially in the shoulder, is a reliable test for a tear in that region, because it's going to be really difficult for a patient to control the descent of the arm if the supraspinatus is torn. It's also going to be really difficult for them to initiate abduction, because the supraspinatus alone in the shoulder is responsible for the first 20 degrees or so of abduction. And then the deltoid jumps in and takes most of the power. So what you might see, and I'll kind of stand up a little bit, one of the first things I usually ask a patient to do is range of motion. You start there. So again, with the arc, you have them kind of supinate the wrist. So my hands are like this. So you have them start like this and slowly make the arc, right? So for those first 20 degrees, watch them do it bilaterally. And if it's even, and have them do it slow. And if it's even and symmetrical, then that's a good thing. That starts to rule out a tear. But if you see this kind of thing, where one side goes up and the other, they lift the trapezius and then engage to get it up, that pay attention to that, because the supraspinatus at the first 20 degrees of abduction isn't doing its job if they can't initiate movement, right? So if they can't control descent, or if they can't initiate range of motion, those are two huge punchlines to look closer for a tear. And then there are the ortho tests that do that, right? So Codman arm drop, the O'Brien's test is a good one for the bicep. The Speeds test and the Jurgensen's test for the bicep also sort of get you there, but that can, a positive test could also mean tendinitis. So it doesn't necessarily confirm or deny a tear. So if a Speeds test and a Jurgensen's test on a bicep, if there's, a lot of pain kind of where the long head of the bicep tendon sneaks in to the groove, the bicipital groove of the shoulder. If the Speeds and Jurgensen's tests are nice and strong and there's no popping or clicking, I don't always assume there's a tear and add the O'Brien's test. But if there is a lot of popping and clicking and those two are positive and weak, then you could do the O'Brien's, which is, again, the empty hand movement across the body. And then you push down. And if that would be really weak if this was torn. And then you have them supinate the hand, push down again, and that should be stronger. And that's a positive test there. So let's see what else. For tendinitis, a super reliable test for the supraspinatus is the empty can. So that puts the supraspinatus in a vulnerable position and it really sort of isolates it well. So if you can drop, another thing is assessing kind of the strength, right? So if the patient can maybe get there, but if you can take them down with very little pressure on that side, or they don't even try to resist, that points to a possible partial tear. Or the more weak something is, the more injured it is, right? But if it's strong against your resistance, but it just causes pain, that points more towards tendinitis. History is super important too. Is it a chronic issue? Is it acute? Did they hurt themselves? How did they get the injury? So all of the history taking in the conversation is also adding to your differential diagnosis. But tears, usually the patients are in very excruciating acute pain, and there's a lot of restriction in range of motion. They also tend to get worse over time. They don't necessarily get better, right? They might start to improve with your treatment, but if you just kind of strain a muscle, usually in a couple days, naturally, it kind of starts to feel better. But popping, clicking, catching, all of the little kind of snapping noises point to taking a closer look at attachments and tendons and ligaments. And it doesn't always mean a tear, but it points you to that tissue, and that tissue is very vulnerable to tearing. So, I mean, if you can hear in this long-winded answer, we don't always know for sure, but we have reason to believe based on some of these other tests. So let's see what other signs and symptoms might we, so for impingement, you asked about impingement in there. The painful arc test is the most reliable for that, because, here, let me pull up our slide, just the still. We don't have to watch the video unless you want to. Okay, let's see. Hang on. Okay. So if you remember this slide here, so this little diagram, right? So when the punchline for impingement, if we're just talking about impingement here, it's gonna feel better at the last 10 degrees of abduction, usually, because the space in the acromion actually opens up at the end there. So there's usually no pain at the very beginning, and then you get, a painful arc, painful arc, painful arc, painful arc, and then at the top, tippy top, you get more space, and it tends to provide relief. So that's the first thing I think about. And make sure too, if you're guiding a patient through the painful arc test, that you make sure that they get all the way to the top and actually join their hands. Because that last 10 degrees, people tend to want to give up on that. And they don't always realize or know that at the last, that little last bit actually feels better. They'll kind of stop before that. So if they can, you never want to push somebody into a movement or action where, it's causing a tremendous flare. And if it is painful, where did we go? Where is it? If it is painful at the very, very top, that kind of crowds the acromioclavicular joint. So you might want to think about an AC joint strain there if it is painful at the top. But supraspinatus tendinitis, it can also, it can look like impingement. So yeah, some of these things, it's like we can, bursitis and impingement can kind of be suggested by these tests. Bursitis we didn't talk a whole lot about, but the bursa that is usually most inflamed in the shoulder. Are you all still there? Okay, yeah. I thought I lost you all for a second. It's usually right. It's pretty superficial. So there's usually point tenderness right here for bursitis, but we didn't really go over that. I don't know if that answers your question, and if we want to look at the elbow too.
Yeah, it does.
It's helpful.
It wasn't specifically a question, just wanted more discussion.
No, that's good. That's great. Yeah. And it continues. I mean, take comfort, or maybe not, in the fact that there is a lot of ambiguity out in the world too. I mean, I don't always know for, certain if something's torn or just strained or sprained. And let's look at that really quick too, actually. And what I tell patients all the time is their response to treatment is also really diagnostic. So if something's not responding reasonably to our treatment after a handful of visits, and you'll get a sense, the more and more patients you treat, like how quickly something's going to resolve. But if it's tendinitis and muscle pain, or just little strain, it tends to resolve pretty quickly with our treatment. So if after 3 or 6 visits you're not getting anywhere, then my antennas really go up, not only for tears, but for other space occupying lesions, like a tumor or some sort of cyst or something that's somewhere that we can't palpate that might be irritating a nerve tissue. So all of the things, no matter what part of the body or what condition, if something's not getting better, if the patient has systemic symptoms like Fever, nausea, night sweats, things like that. And when you see somebody, you also get a sense of their constitution, right? So if their overall health is also sort of suffering along with a specific part of the body, you want to pay attention to them internally. I mean, we want to do that anyway, but if someone's really healthy and athletic and they're really in tune with their body and they're just, they're using those tissues and they're eating well and their systemic inflammation is low, it tends to be more straightforward ortho in that case. Okay, so what I wanted to point out, and let's just look at this really quick because this was a long time ago. Okay, so let's pull up. A strain versus a sprain. Remember this? So sprains involve ligaments, right? And strains involves tendons or muscles. So an ankle sprain, right, is ligament. Ligament connects bone. Tendons connect muscle to bone. And they have different grades. So this is where it gets a little ambiguous for us. So grade 1 is just a little stretched. So that wouldn't be picked up on an MRI or any imaging study. And we see this all the time in joint spaces and this tends to be in, kind of it can happen in an acute case that's just a minor injury, but also in chronic pain where something's just, it's been going on for years and years, and maybe the patient's done a lot of physical therapy and they're very strong, but they continue to have some pain. So in that case, you want to explore those tissues to see if there's any hypermobility that's detectable. And in this case, it's really valuable for us to aim our needles at these attachment sites, because if something's just a little bit stretched and hypermobile, it can stay that way indefinitely. And it happens in ankles all the time. So when we go through and we poke little holes in some of these fibers that are less vascularized than a muscle, they tighten up. So that tends to be the thing that can kind of push an injury towards healing that might be chronic. And then grade 2, partially torn, right? So some fibers might be torn or damaged. Again, we might start to see that on an imaging study now, but it could be really subtle. And we can still help, especially when we poke around and kind of wind our needles around some of these fibers and kind of, connect them all and use our e-stim and our herbs and all of those things. But maybe takes a little longer to heal. And then grade 3, complete tear. So again, this is like you're not getting anywhere, they're not getting better, or maybe they get a little bit better, it comes right back. There's a lot of guarding, there's a lot of pain, there's a lot of weakness and difficulty controlling muscle movement, whether ascending or descending. That's when we tend to think of a tear, a grade 3. So let's see, let's go back to, I want to also just make sure. So everyone seems okay with these directional terms.
I feel good about like the flexion, extension, abduction, adduction, but the slide before the planes of motion that one I get a little confused about. I understand that or
Okay. So this one here that I'm on.
The one below it, I guess it's the same thing. Maybe it's just that picture. Yeah, that's the one I have trouble with.
Oh, this one here.
Yeah.
Yeah. Yeah. So this one, yeah, this is kind of tricky. This one, don't stress about this too much in the context of the test, but this is important to understand, especially when we're looking at imaging studies. And it helps us when we're thinking about something like a shoulder or a hip or a joint that moves in multiple directions. You're lifting up the arm, right? But you can lift it forward in front of you, or you can lift it to the side, right? So if you're lifting it forward in a sagittal or longitudinal plane, when we're talking about the shoulder, that's flexion. And then if we're reaching up in this direction in the frontal plane, right? That is abduction, right? So sometimes, when you're reading a description of a specific movement of a joint, it can still be unclear. Well, is it forward and up or is it out to the side and up? And that's where it gets a little hazy. So I snuck this in here because when we're looking at this slide, you kind of need this slide in order to understand what I'm talking about. So as long as you get that flexion is in the sagittal plane, whereas abduction is in the frontal plane, then you're good there. And then other things, parasagittal, median, all of that, that's like, that's detail that could help you sort of orient your attention to what you might be looking at in an imaging study. But the frontal plane is an important one to understand. The horizontal, axial, right? So when we talk about the axial plane or the transverse plane, we're talking about the axial. When we talk about the axial skeleton mostly. I don't want to add more information than you need actually before your test. So the frontal plane and the sagittal plane are the two that are the most important to understand the difference between flexion and abduction, given that those are like upward movements in two different planes of motion. So I hope that helps.
Yeah, thank you.
Yeah, you're welcome. Okay, good. Is there anything else in this directional terms of movement slide that confuses anyone? Everyone's good on the difference between pronation and supination. So I always remembered supination as being like, yes, it's external, it's lateral rotation, but if you wanted to hold soup in your hand, you'd have to hold it up like this. You couldn't hold it down or the soup would fall out, right? That's how I remembered it. And then internal rotation and external rotation, when we're talking about the hip and shoulder, can get a little confusing too. It's nice to associate those things with medial and lateral, but it's also not that straightforward, right? When we're talking about a joint that rotates in so many different planes. So internal rotation is medial rotation. You're turning a limb around the long axis in the direction towards the midline of the body. But with the shoulder, if we keep going and curve it around, right, think about what the ball and socket is doing with internal rotation. You're turning it kind of towards the median plane, right, and reaching behind. Whereas external rotation can be as simple as this, but if we continue with the shoulder, we can reach out all the way behind us. And then that ball and socket is really rotating laterally, right? So that's another one that's a little funky. So let's see here. Do you guys feel good about bones? The osteoblast building bone, B for build bone, and osteoclast, C for consuming bone, reabsorbing bone. We have to do this all the time, and it's the most amazing thing that we're constantly building bone and also reabsorbing it and taking calcium and different nutrients from the bones and giving it to the blood and the heart, and just, you know, continually establishing that balance for better and worse. But it's, I mean, bones are fascinating. They're one of my favorite tissues. So just, you know, understanding that bone regulation, just the age of your patient, their health history, their body type, their constitution, that can tell you a lot about the integrity of their tissues, right? Even at the bone level. I mean, this is like yin deficiency, right? So partially, there's a lot of other things that constitute that, but weight bearing activity, that's why it's so important to kind of give our bones that that message and that pressure. And that could just be walking, but light weights, you know, just to remind the bones that we still need them. So, and electricity, right? So e-stim is great to stimulate tissue healing. And then bone withdrawal is going to be inhibited by, it's another way to say, or similar but slightly different to stimulating bone deposition, right? So we're adding bone, or we are inhibiting the process of removing from it. So that is very hormonal. So estrogen and testosterone sort of protect our bones. And so in a stage of life where some of the androgens in the body start to become a little deficient, our bones will also weaken in response to that too. So menopause is definitely a time in life where bone density can start to diminish because of that. So just want to make sure you guys remember all of that. Let's see. And this is kind of the same way of explaining the previous chart, just in more detail. Do you remember this slide? Everyone has osteoporosis, osteomalacia, arthritis, osteoarthritis, and osteopenia. You have them all straight. You're going to hear these terms all the time, so it's good to know. So let's see if there's anything else.
Jennifer, I kind of have a question.
Yeah.
It's not on this slide, but it does deal with osteoporosis. It's
Uh-huh.
like one of the questions you put down as a multiple choice in one of the slides. And the answer is osteoporosis. Let me see if I can, maybe I'll unmute and I'll find it, and then I'll mute and then I'll unmute again when I find it so I can ask you.
Sure. Yeah. Is it in, it's not in this lecture? I'm scanning it.
It's like it deals with this information, but I don't know what lecture, like PowerPoint it's
Okay.
in. So I'll look for it and then I'll bring it up again.
Sure. Does anyone else have any questions in the meantime? While we're thinking about that. Does everyone feel pretty good about just a general sense of some of the TCM patterns that we might find in some of these things? Here, I'm going to pull up a slide. One of the more overwhelming ones.
Hi, Jennifer. I found it.
Oh, you found it. Okay.
Yeah, this is Lauren, by the way.
Yeah, hello.
Hi. So this is under the spine differential diagnosis. And it's page 35. So it's like a red flag.
Oh,
it's
yeah.
after the cauda equina syndrome slide.
Yeah.
And so the question is, an elderly woman with severe central thoracic back pain might have A, a spinal tumor, B, a pathological fracture of a vertebral body, C, osteoporosis, or D, all of the above.
Yeah.
And then I think I just don't really understand this slide. Like, I'm guessing that the answer is osteoporosis because of the answer that you wrote.
Yeah.
But I don't really know why it's not the other ones, and also like why it's here.
Yeah, very, very good question. I'm so glad you brought that up because we sort of brushed over the thoracic spine. The thoracic spine, I will just say, is a very difficult place to injure unless you fall directly on it or you have some trauma. You're going to start to see a lot of, there's so many muscles that cross the thoracic spine and the shoulder girdle that can get really sore and achy, you know, the rhomboids, the traps, the lats, the serratus. But that's not necessarily a result of the thoracic spine being injured, just because, one, it connects to the rib cage. Two, its job is to protect our vital organs. And so when we flex, we're mostly hinging from the lumbar spine and loading that. When we sit, we're loading the lumbar spine. When we flex our neck, you know, we're hinging from up here. So the thoracic spine is not commonly injured. And so there tends to be some red flags around it that might kind of tune your attention to some other concerns. And you start to see thoracic back pain in elderly people a lot more commonly. And they don't have a lot of muscle bulk and mass. It tends to be the patients, and I can think of at least 3 off the top of my head, that are elderly and frail, and the muscle tissue is, you know, they're not super, you don't assume that, you know, they have a rotator cuff injury or anything like that, but it's pain in the thoracic spine. So in that case, you would want to think, or especially if it was a younger person too, if there's unrelenting pain and you're treating them for, you know, muscle aches, let's say, you know, they have pain kind of near the thoracic spine, you might feel a mass, or they might have, you know, you might be treating the muscles, and you're not getting anywhere, and it's just really unrelenting thoracic spinal pain. You want to think of some sort of mass or tumor or cyst that could be irritating the nerves along that pathway, right? In the context of an elderly person, it doesn't take much to fracture a vertebral body of the spine, and that can happen with very little pressure. So it's and this recently happened to an elderly patient of mine who got rear-ended and had really severe pain in the thoracic spine. And so I sent her right away to just get an x-ray, because while, you know, a younger person might just get a little whiplash or a little soreness, you could definitely, very little impact might cause a thoracic spinal injury. So the intention with this slide is not only to point out what might happen over time with an elderly person, but to to kind of shine a spotlight on the fact that the thoracic spine in the center of the spine has more red flags because it's just such an uncommonly injured spot, right? Unless it's muscles. So osteoporosis is part of this. So all of the above is the answer to this question. And this was just sort of a reminder of what osteoporosis is. And so, you know, it occurs when we lose bone density. Bones become weak, brittle, dangerously susceptible to breakage that might be atraumatic. So an elderly person might, again, because they're not, you know, they're not out there running or doing a lot of activity, they can have kind of really, really intense pain in bones, and they might not recall falling or injuring themselves at all. It can be an atraumatic fracture. So does that clear it up a little? Does that help?
Yeah, no, that helps a lot because I actually thought the answer was osteoporosis because on my like PDF, it's not bolded and bigger and in yellow. So
yeah,
just because you had that description, I was like, I guess it's osteoporosis. But when we were studying, it's like, why isn't it A or B also? And then I guess just to clarify what you said, or make sure I understand, these are basically red flags of a thoracic back pain for like older people. Okay.
Yeah.
Okay. Yeah, that makes sense. Thank you.
Yeah, you're welcome. And I want to I think I stopped sharing. So let me share again. I want to look at the next slide too and just make sure that you all feel comfortable with it. Because again, I just can't thank you all enough for your patience as I kind of try to navigate through how to teach this class in the best way, especially since you have to listen to me talk for 3 hours and it's less engaging. You know, the TCM part of it all, and I'm going to try to, because I get a sense that a lot of you are really interested in that crossover, and that really makes me happy. So I don't want to continue to kind of like leave it to the end and rush it through. And I assume it's more intuitive to you all. Because you kind of have the TCM lens. And so, you know, if you just have a little nudge, then, you know, you can draw these conclusions. But I'll try to just create a little more time and discussion around the TCM crossover because it is, I mean, that's the nature of our medicine, right? So this slide here, I want to try to stop doing this to you all. But, you know, different conditions orthopedically may have more possibilities than others. And so I don't want to overwhelm you with everything but the kitchen sink. And really, I mean, I also want to say this part of it really comes down to your sensitivity as a TCM practitioner too. It can, I'm sure there are many other patterns, especially for, you know, the arm and the wrist and the elbow that I'm not calling attention to, that can absolutely be a factor, right? But this particular slide, this was early on, and I didn't really talk about a lot of detail on, you know, the nature behind these patterns. But this kind of just comes more from like our classic understanding, like the Bob Flaws sort of lens on, you know, what can create these different pain patterns. And so, yeah, I just want to make sure you all, you know, remember this slide, but you know, wind cold, wind damp, wind cold damp, cold damp, damp heat, you know, all of our external pathogenic factors can join together, and that's going to, when a tissue superficially is weakened, we've talked about before, it opens the door wide to vulnerability for, you know, all of these external pathogens to kind of get stuck in our tissues. And so, you know, in the back of your mind, we're always thinking about that. And I admit, if I'm seeing someone, especially if I'm pressed for time and it's just ortho and I'm like, okay, you know, I kind of know what's going on. I sometimes I forget to check the pulse, and I just, you know, jump right into the treatment. But that's important because, you know, constitutionally, we always want to be paying attention to how these things might get stuck in the body. And so, for example, there's a lot of surfers around here, right? What are they doing out there? They're in freezing water. It's windy, it's cold, it's damp, and they've got rotator cuff issues. And so, you know, in that case, I always assume with surfing injuries, even if they're a young person, you know, that tissue, if it's weakened and there's stagnation and there's a lot of blockages in the soft tissue that aren't able to circulate qi and blood throughout the entire pathway of those tissues, damp and wind and cold, yeah, it's going to get stuck, and it's going to feel better with warmth, right? Constitutionally, if someone's really inflamed and they're all red and they're hot and their joints are hot, you know, I mean, there's usually really obvious signs of heat. But I want to make sure the takeaway and the punchline is that, like, inflammation in our medicine is not always assumed to be hot. We're all warm-bodied individuals. But again, I may have mentioned this before in this class or other classes because I say it all the time, but we're all, you know, crudely, we're either a rare steak or a well-done steak or anywhere in between. And we can be a combination of all the above, right? We can have tissues that are rare and some that are well done. But, you know, this concept of cold, inflammatory cold is amazing from the perspective of Chinese medicine. And so, yeah, inflammation isn't always necessarily, even though there could be heat, that's usually in a really acute phase. So that's the only time where cold could be therapeutic. But ask the patients, what have you tried, heat or cold? A lot of times they keep forcing the ice and it doesn't help, but they just think to do that because of inflammation, and they're just, everything about them is cold. So in that case, you can suggest they try heat, and if that makes it feel better, that tells you something, right? Liver qi stagnation. Oh my goodness. That's on here. Neck pain, low back pain. Yeah, absolutely. You know, all of this stuff. And the neck pain, lung and stomach heat, you know, like think about, you know, heat's gonna rise, right? So liver yang rising, lung and stomach heat, that can all sort of get stuck in the upper tissues. So yeah, all that to say, not everything is qi and blood deficiency. And depending on someone's age and their background, yin deficiency or yang deficiency, yang is movement, right? So lack of circulation and lack of moisture in the tissues and things like that are all considered yin and yang deficiency. So let's see. So does anyone else have any questions? Do you feel ready to take the exam? Do you want a little break? Or I can, I'm going to post it. Yeah. Hi, Melinda, is that you?
Oh, yeah, I was just going to ask for a little break, but then you mentioned it.
Yeah. Yeah, I think that's a great idea. If you don't want one and you just want to jump right into the test, go for it. I'm going to post it in just a minute to the streaming page, so it'll be a link. And And let me just see who's still here.
You mean you're going to post it in Classroom?
I'm going to post it to the streaming page. Yeah, of our class. Do you know what is that clear?
Yes.
Yeah, okay. Yeah. So I'm going to post the link there. Right now. And so if you just want to jump in, there it is. And if you want to take a 15-minute break, go for it. I'm going to stay here until everybody's done taking the test. I will be available for questions. Try to keep it to 75 minutes. Like I said, that's reasonable. Stay logged in, please. And let me know. I'm going to keep an ear on the chat. Let me know when you're done so that I can confirm that I've received your test. And please make sure you hit submit, because I think I don't know if I mentioned early on, there have been some funky things with these tests that I've experienced more when we were doing more quizzes. So make sure that you let me know so that I can, if you log out too prematurely and there's like one submit button missing, I might not get your test, and I would hate to have you have to take it again. So with that, have at it. And if you'd like to start your test in 15 minutes and you want to take a little break, go for it. Okay. Good luck. You'll all be fine. And I'm here for questions. Just gently checking in out there, making sure everyone's still doing okay. Don't forget to check in with me in the chat as you leave, just to make sure. I'll check right now. No pressure. No pressure. Keep
Okay,
on
still
going.
working on it. Thanks.
Yeah,
Still
no,
working.
you've got it. No rush. No rush. Just a reminder, and there's no class after. So, all right. Let me check on a couple of those. Hang on. Yeah, got it. I see it here, and I will make a note that that's the email, but I'll have to see on the back end if that's going to be a problem. So definitely try to log into your own computer, because my feedback and response is going to default to somebody else. So I'll try to fix that. But I got it. So let me just make sure that I give you credit. And I'll let you know if there's any problems, okay? But I do see it. Okay, have a great weekend. Bye.